Hello, everyone. Thank you for coming. We'll give everyone some time while their audio connects.
Good morning, everybody.
Morning.
I think we'll do the usual couple minutes after the hour to accommodate everyone able to join.
Yes, Laura Rose.
Hey, this is Laura Rose. I just want to say thank you that the invitation this time had the Zoom link and I was able to finally access it on my phone without
Wonderful.
issue. So that made a huge difference for accessibility. Thank you so much.
You're welcome.
Looks like things have slowed down, people joining. So maybe if we could go to our housekeeping, please.
Wonderful. Thank you so much, Chris. So welcome, everybody. Today is September 23rd, and welcome to the Behavioral Health Crisis System Advisory Committee. My name is Bella Bradford. I use she, he pronouns, and I am the lead for this committee. One moment while I share my screen. Okay. Can everyone see my screen? Thumbs up would be just fine. Okay. All right. So for the Zoom navigation on the bottom left-hand corner there, if you want to mute or unmute yourself, you just click the audio button. If you want to stay on mute, you'll see a red line going across the microphone there. If you want to be on video, you would unclick the video button and then you will show yourself there. You don't have to be on video, however, if you don't want to. And then we do have interpreters in the room with us today. If you would like to hear what they might say based on if we need their services today, you would click on the globe there that says interpretation and select English for you to be able to hear what they're going to say. Captions can be enabled in Zoom. If you have a question, please put it in the chat box, unmute yourself or raise your hand, whatever you are most comfortable with. Please introduce yourself the first time that you speak, and also please share your name, pronouns, and any visual description if you feel like doing so. We are in community. Listening to one another, respecting one another, and sharing space with one another allows us to be in community with one another. And it is okay to have different opinions, but what is most important is that people are in a space where grace and respect are valued and we all can learn from each other. Please be present, intentional, and grounded. Create space for multiple truths, value perspective from different backgrounds, assume best intentions with open-mindedness and curiosity and allow fresh perspectives. Recognize that intent is different from impact. Make space to uplift others. Speak from your own experience. Share the outline, not the details. Stories stay, lessons go. Honor the quiet voices. Step forward, step back. Use inclusive language that is accessible for all. Please use the chat box for acronyms. Take care of yourself, the group, and each other. And if we don't have any other questions, we will go ahead and begin roll call.
Amy
Yes.
Fellows. Oh, sorry.
Oh, sorry. Yeah, please, let's go to roll call.
Amy Fellows.
Here.
Brent Wolf.
Yeah,
Cheryl
Brent's on.
Ramirez. Okay.
Brent's on.
Cheryl Ramirez. Chris Banoff.
I'm here.
Daniel Brown.
Here.
Erica Strohan. Greg Borders. Jennifer Fraga. Juan Villalobos. He's here. I saw him come in. Lane Miguel.
I'm here.
Laura Rose.
Here.
Robin Henderson.
Here.
Cherie Eyre.
Here.
Stacy Brubaker.
Here.
Stephanie Watcher. Talina Ali. And I just let
Present.
Tina. Okay, perfect.
Okay, we've established quorum. With that being said, I'm going to pass it over to Chris.
Great, thank you. And on behalf of my co-chairs, Shri and Danielle, welcome to our meeting this morning. Looks like Juan Pablo has got some problems with audio, which is why he wasn't able to chime in. We have a pretty full agenda today, so let's just get right into it. And I'm going to turn it back to our partners at OHA for their standing updates section. So please take it away.
Thanks, Chris. Hi, everyone. Lauren Palma. I use she, her pronouns. I'm the interim manager for 988 and Behavioral Crisis System team here at OHA. I am not sure if I saw Ebony on the call quite yet. Ebony, are you here?
Ebony is at an in-person event that I'm driving back from. This is Krista, by the way.
Great.
Ebony will
Krista,
be late.
did you want to do the introduction of the new Policy Director and Chief of Staff, Jill Archer, on behalf of Ebony, or would we like to hold that?
I think she is so excited about this that I would love for her to be able to share the good news.
Okay, great. While we have you on the phone, Krista, are you able to give any federal impacts updates?
Well, good morning, everyone. This is Krista Jones. I use she and her pronouns. I'm the Deputy Director for Behavioral Health, and my area of focus is called service delivery, which is child, family, lifespan, and adult behavioral health. I am a part of the federal response team, HA, and what we do is we get together weekly as leadership team to talk about the different elements that are coming out from the federal side, and we are coordinating ourselves around the new information that we receive to analyze the information and to best understand the impact. As you all know, that you can read in the news and just probably very likely becoming more familiar with are the impacts on Medicaid and the impacts just on our behavioral health system. And we are, continuing to work through those details. And we'll be offering a provider session, which I believe is going to happen the 30th of September. It's a provider listening session where leadership and communications folks will be offering more details about the work that we're doing. In addition to that, Ebony Clark, our director, is also going to be hosting a space with the CMHPs or AOCMHP. I believe it's this Friday, to also keep them in the loop and to continue dialogue and discussions around the changes that we're seeing. So I really encourage y'all. I think that the link to the website is on the agenda for this meeting. I really encourage you to go there. They're updating information much more frequently. And so that's where you're going to have the most accurate fix that we are working through. So that's what I have on this.
Thanks, Krista. And we'll make sure to add the link to the meeting notes for everyone.
If I might, just a question. So you're having listening sessions with some key stakeholders. Is there anything that will be coming out in those sessions that is different than, say, this body may find on the website, or how, what would be specific in those sessions that might be helpful for us to maybe know?
Sorry, I couldn't come off mute. I think as details unfold, that is a really good place where I think the community will get more around the impact. I believe that there's some detail around the Medicaid impact. I believe there's just different speakers that come from a variety of leadership positions within OHA to talk about the impact of their work. Yes, and I think that the website is also a really good place.
Okay, not seeing anybody else coming off mute or anything in the chat as far as a question. I'm going to move us along. We have John Collins here to answer any questions that may have come up from the IMD waiver letters that were shared out with last meeting's meeting summary, as well as with the agenda for this meeting. So I will open up the floor and see if there are any questions from anyone for John.
I know I do have sort of a question, but I'll hold off if there are others. I'll let them go first.
Maybe you should break the ice, Chris.
Yeah, okay. Well, so I read each letter, and my takeaway from it is that the sort of the based on the guidance from CMS that exists in these kind of series of questions, that it was the interpretation maybe that it would be more likely than not that some of these projects that were the subject of these letters wouldn't qualify for Medicaid reimbursement. And because of that, so where I sort of fell down though is it the state that ultimately though makes a decision to try to turn on the Medicaid spigot in those projects, or is it like what is the mechanism by which, let's say, they go forward? Does CMS do an evaluation up front saying yes, these are IMD, no, they're not? If they do go forward, is the state then going out risking, based sort of on the analysis that I read in the letters, if it says, okay, we are going to reimburse this for Medicaid, but if CMS comes back and retroactively says, hey, no, these are excluded, then there's a clawback. Like what I sort of didn't understand is the mechanics of how that plays out, let's say if a project does go forward.
Yeah, thanks, Chris. And for those of you who don't know me, I'm John Collins. I'm the Deputy Director for the Behavioral Health Division, and use he, him, his. Well, the answer to your question, Chris, as you can imagine, is a little complicated, but I mean, essentially the entity that holds the ultimate authority on deciding whether or not something is an IMD is CMS. However, they rarely get involved in those decisions. There have been times where they've been asked to provide some heightened scrutiny when that was needed. It's usually not done on the front side like most of the investment situations that we've been dealing with. The way the state works, though, I mean, we have our interpretation of the guidance that they've given us, and we've worked with DOJ to try and go through some of the grayer areas in that guidance. Although I will acknowledge, and DOJ would say, I believe the same thing, that there's still there's some grayness. So ultimately, we go with what DOJ has advised us, and they're advising us based off the risk they see associated with a facility being seen as an IMD. And our goal is to, while we're trying to increase capacity and address all the various gaps that exist across the state for the types of capacity, we are not in a position where we can allow or invest in a program that would have to be strictly reimbursed with general fund dollars. So we have, in interpreting some of the various projects that have come forward, we have gone with our guidance from DOJ in terms of what would or wouldn't be an IMD. And I mean, that's the way we responded to the request. I mean, I wish it was and I know I wish it would be, and I'm sure many of you and your partners out there wish we could just provide a definitive yes, no. And we do have the ability to do that in some situations where it is clearly a yes, no, but in those gray areas, we unfortunately cannot give legal advice. We can tell the entity how we would interpret it, but they are also welcome to pursue their own legal interpretations and even consult with CMS. But ultimately, it lies with the state to go with where they feel things are on the side of the risk issue and reimbursement.
Right, because it's the state that would ultimately say, okay, we're going to go ahead and use Medicaid funds.
Yeah,
So
payment of any services there.
yeah, and so the risk in this case, as I read these letters, there was indeed risk that if that happened, the state may be on the hook for paying those dollars back because somewhere down the road, someone could say, hey, these are not Medicaid reimbursable.
Exactly.
Yeah, okay. Cheryl, I see your hand up, please.
I certainly understand the position Oregon Health Authority is in. We did get our own legal analysis. I don't remember if that was attached to these letters, and we did send that to Oregon Health Authority. We did meet with the Medicaid director first at Oregon Health Authority, Emma Sando, and she gave us a direct contact for CMS Regional in Seattle. So we are going to pursue appealing to CMS on these issues. And we're also going to meet with members of Congress about
Right.
this.
Yeah, and I'll note the information that Cheryl and the AOCMHP sent to us actually did play a role in changing some of the way we looked at IMD as we went back and our Department of Justice went back and looked really carefully at things. There were certain pieces that we had had a long-standing kind of decision on that moved things towards an IMD that were changed as a result of the heightened information that AOCMHP sent to us. I will say though, and I think this would be CMS's response too, but I know it's certainly DOJ's response. Each of these is very individual in terms of its interpretation. So it gets really hard to put out blanket information, except on some of the very, as I mentioned earlier, some of the very concrete criteria associated with an IMD.
Right. And it looks like from Lauren's comments in the chat, Cheryl, the letter that you guys produced was not shared with the group. I wonder if we could make that possible to,
Yeah,
we could all see that analysis. I really,
it's the letter and the legal analysis.
I think both of those would be
Yeah.
helpful.
Yeah,
Yeah.
that's fine.
I found the letters that OHA wrote to be very helpful in understanding sort of the dynamics at play. So Lauren, please.
Yeah, just wanted to say Cheryl, I only have the letter that you sent to OHA, not the legal analysis. John, it sounds like you might have it, so I'll just get it from you and we'll share it out with the notes.
Sounds good. Thank you.
Yeah.
And I'm glad to hear that, Cheryl, your group is pursuing more clarification in the hopes of maybe winning the day.
We
Okay.
can only hope. And by the way, this was encouraged by the Oregon Health Authority. We're not doing anything that they don't, they don't support. So just wanted to put that out there.
Before turning it back to Lauren, are there any other questions or comments on this topic? Okay. Not seeing anything. Thank you for that discussion. Lauren, back to you.
Thanks, Chris. Thanks, everyone. We have one more thing on our standing updates before we turn over to the larger part of the agenda, and that is the Crisis Stabilization Center's work group. You should have all received an invitation to join this work group if you choose to. This is coming out of all of the community engagement and the RAC sessions for the Crisis Stabilization Center rules and a variety of different opinions on approach and conflicts. And so instead, we're taking a step back and asking this work group to work through that rule language together. Completely voluntary. This is not a part of BookSac, but we did extend the invitation to BookSac as well as many, many other partners, and really looking forward to engaging in that work group period of time. This is time limited. It will not be extensive, and all of that is laid out in the introductory email. If you have any questions, please do reach out, like Juliana just put in the chat, directly to her. And we would be happy to get you all connected, and looking forward to the work that this work group does.
And I guess I will add that the health authority has asked me to be one of several facilitators of these meetings. So I'm hopeful then when a new draft comes back to BookSac for comment, we'll have a little bit less. We'll have a product that is more in line with the vision, that the shared vision I think we've all sort of built over the last couple of years. So I think being in front of this more rather than reactive will hopefully prove fruitful and helpful. Okay, so that's Lauren, I think that concludes then that section of our agenda. Is that correct?
There it does. Yep.
Excellent. So we have a discussion now. We had a level setting of our rules around mobile crisis and stabilization services, particularly for youth. And I think we're having part 2 of that discussion where we're really looking at some potential proposals or new language, and they're seeking commentary. That went out, I think, a red line version with the IMD letters, so you'll find that as an attachment. And so I will turn it over to Juliana and Brian to lead us through this section of the discussion.
Thanks, Chris. Hello, everybody. Nice to see you again. My name is Juliana Wishers. I use she, her pronouns, and my role is I am the 988 and Behavioral Health Crisis System Implementation Coordinator. Brian is going to pull up our rules.
Right. I'm Brian Pitkin. I use he, him pronouns, and my role is the Children's 988 and Mobile Response and Stabilization Services Coordinator. And I threw the link into the existing Secretary of State website for the Division 72 rules. And then, as Chris noted, we did send out this document to folks, which is the red line version of the OARs, to get input. And so that should be in your email from the BookSac from Bella.
I don't know if you're just meaning to screen share that document itself, but we're looking at a desktop currently. So not the document itself, at least that's what I'm seeing.
So you saw my messy desktop?
Yeah, I did. Actually, it looked neat. It looked much neater than mine. So congratulations.
It's alphabetized, but I didn't.
There, you've got it. Thank you.
Okay, I apologize for that. And then I'll just show this off real quick too. In case you're using that link there in the chat, this ought to be where you land, which is that Secretary of State website.
Great. Thanks so much, Brian. So like Brian mentioned, we went over like Chris mentioned, we did a level set of the existing rules last month. So this month, what we're going to focus on, since we read almost everything from the last rule set, although we did really focus on those service delivery areas of the rule set, we're going to look now at the entirety of the rule set. But only the changes that we are planning to make. Most of these changes are based on feedback over the last 2 years or so from our providers of mobile crisis and mobile response stabilization services. So as we go along, you'll see in the notes there kind of our reasoning for why we're looking to change it. We've also got some things that we really want to present as a discussion area to make sure that we get feedback from you as we're doing these revisions. So you'll also see that outlined kind of as a topic for discussion. So feel free to use this space to provide feedback. And if for any reason you don't want to provide feedback in this space or you want some more time to think about it, we'll also accept written feedback, or you can use the chat for that. I will try my best to monitor the chat, but I'll also be relying on my colleagues to call things out from the chat as well, also to make sure that that ends up in the transcription and translated as well.
Juliana, I think the first ask is if Brian can Zoom for, I
Okay,
know my
great.
old lady eyes. I know it's hard because you want to be able to see the comments on the side. So I don't know.
I can read in on this copy, Chelsea, and then Juliana can read out the comments as she's going through it for those discussion points. Would that work for everybody? Be the easiest?
Yeah, what's best for the group? Not, I have seen it, so, and I can pull it up on my own screen. What do you think, Chris?
You know, I look to the group. I mean, I can see, I've got a sizable monitor, so I can see this well enough. But I know there's probably people on some smaller screens.
If you
Yeah,
close
so
the
maybe we could look at the red line and then sort of go to the comment as we stop at each of the red
Yeah,
lines.
that's fine. I have a copy up on my monitor here, and I do plan on reading verbatim what you would have seen on the screen as well. So you can hear exactly what we have written down there. Just another note, there will be some things that are redlined that we won't go over, and that's mostly really small changes. So for example, instead of just saying families, we're going to say the individual and their families. There's also a lot of renumbering that we'll have to do. This is still in draft form. So if we change one number, it changes everything that follows as well. So I won't say we're going to change this A to a B or 57 to 58. But if there is something that is a smaller change that I skip over that you do have a question about, feel free to stop me and ask me about that. There are also some things that we change that appear or discussed again later on in the document. So I'll only discuss that initial change. I won't repeat it again. But again, if you're wondering about something, please stop me or put a question in the chat.
One more thing, Juliana, before we get started, that I guess I wanted to say is these changes have not been made. These decisions have not been made. And so this is true advisory. We really want to hear back on anything. And so while it may look, because we're showing a red line or the changes have been made, I just wanted to make explicit to this group that this, again, these are things that we have heard. Community engagement will continue even after this meeting today. So this isn't your last chance to give feedback or to have this conversation.
Yes, thank you so much for making that clear, reiterating that. And just also a reminder, we're coming to you before we start our regular rules changes. So prior to our community engagement and prior to our rules advisory committee. So we want to get your feedback before we dive into the whole formal process. All right, thanks everyone. Okay. So our first change, again, these are kind of that second one there. We went through a reorganization and a name change. So you'll see us change to Behavioral Health Division from Behavioral Health Systems. And our first call out is that our prior rule set actually did not clarify certification to these rules. So there's quite a few additional edits referring to this through 0100, but this is to make it clear that our community mental health providers need to be certified to Division 72 when they're doing mobile crisis services and mobile response and stabilization services. Okay.
So does that mean that they are prohibited from doing other types of mobile crisis response? And I only ask that is I'll ask my question because later in the non-CMHP and as you read these rules, there's a huge dissonance to these rules and that there's no money to do what these rules really call out on a consistent basis. So in many communities where NAMI is, a consistent complaint is mobile crisis is not available. And yet here we are sort of implying in these rules that here's what we're doing. It's going to be available to all people, particularly, it's really very declarative for the non-CMHP to all individuals, to all youth, if they do one or the other. And yet that there is no way that can be reality in our state. So it's sort of, I'm just wondering, what is the expectations of CMHPs? Can they do something different and still get some level of reimbursement, maybe not enhanced or whatever it is? Like, how do you fill a gap that exists because there's just no money to do what these rules line out?
So we do know that there are some other models or other ways of providing mobile crisis. So for example, co-responder model where a mobile crisis team is embedded with the police. So that actually is something that is prohibited by this rule set, that we will only fund just a counselor response model. So yeah, there are some things that this will not fund. There are also these are the minimum standards. So for example, the service has to be available 24/7 every day of the year. That is something that if there's another model that a CMHP is using, we will only certify teams that are doing a 24/7 response. I don't know, Robin, I see your hand up. I don't know if Lauren or anybody else wanted to add to that.
I don't think at this time, we are really looking at statute and ensuring that we are in line with statute and with best practices as well. And so some of these pieces are required through that, and some of them are best practices. So it is not consistent across the board in terms of everything being in statute. That's just not how that worked out. But there are quite a few hands now. So
yeah. So Robin, please, if you would, and then Danielle and Krista.
Yeah, just a couple things. First of all, I understood Chris's question to be the entire system isn't funded fully, but we're drafting these rules. And the answer back was, well, we're only funding the things that we're going to put in the rules, but that's not the case because there's not enough money to even fund the minimum you've got in here. My other question comes to, I can appreciate an ideal that, okay, we would love an ideal where we're only going to fund 24/7 and we're only going to fund the council response model. We're not going to refund a joint responder model. Like if you had a counselor responding in a rural community with an EMT, that would not be funded over here. And I'm wondering what the logic is in that, given that we are a state that has significantly large frontier and rural areas that probably won't be able to meet to what we term as these fidelity models. I mean, I'm in another work group, spent 3 hours yesterday talking about rural and frontier exceptions because all of these fidelity models, are set to a place that they just can't, they don't have the bodies to meet them. So I'm just wondering, I'm curious why we're doubling down on what I've spent half the day yesterday trying to undo.
There are some hands ahead of me. Lauren did mention in her response that some of these are statutorily driven, is what we've been directed to do. So like that 24/7, that's what we've been directed to do by legislation. But I will pass to, I think Danielle, you had your hand up next.
Yeah, thanks, Juliana. I have two questions. In talking about that the services won't be funded by OHA, does that include CCOs who are responsible for funding these services? And I'm thinking specifically about the sort of workaround for this is probably either a Krista or not a Juliana question, or Lauren question. the old model allowed for the H2011 to be billed without a modifier and get the old code reimbursement versus the new code reimbursement. Curious if that's what the intention is, or if the ability to bill without that modifier completely goes away. So that's my first question. I'll pause and then I do have a second question.
Lauren, do you have an answer for Daniel's question?
Yeah, I can answer. The H2011 without the modifier does not go away. That's been used by so many other providers, so that's not leaving. As of right now, the CG modifier is also not leaving because of the one-person response that's allowable to the hospital as well. However, statute does say that it is a mobile crisis team. That means 2 or more. So that is where the 2-person team outside of the hospital setting does hold here.
Okay. So for regions, and Lauren, you'll know what I'm talking about, for regions where the CMHP is not certified, what is going to be the plan, sort of doubling down on Chris and Robin's comments and questions? How are we going to address that in regions where we don't have a CMHP that's certified to do the 072 rules? This feels like a snowball that has a circular conversation that we can't really get to an answer. And perhaps that needs to be a smaller conversation, not in the scope of these rules. I'm worried, same as Robin and Chris, that we're putting these rules in place, knowing that we have CMHPs that are not going to be able to meet them, and then OHA is saying we're not funding them, and then for the CCOs who are smack in the middle, we're having to navigate these conversations where OHA is saying not eligible, can't fund them. CCO contract says must have these services in place, but we don't have the authority to work around the rule set or certify an alternative program.
Yeah, Danielle, I agree that this should be a smaller conversation setting because we're talking about 2 CMHPs that are not certified yet due to not meeting 24/7 requirements. So those have to be handled on a case-by-case basis.
So I'll make this last comment and then leave it, because I feel like I've beaten a dead horse over the weeks. I can tell you firsthand, these services are not available 24/7 to everybody who needs them. They're just not. As a practical matter, here in the Portland area, getting Project Respond to actually respond is a challenge when somebody needs them. So law enforcement is still a default responder in many communities. And we hear that time after time after time after time. And here's somebody certified that they could do 24/7. That's one thing, but these rules set up an expectation that this state cannot meet. And that dissonance, I think, does harm in terms of the reputation of our behavioral health system, because we're setting up expectations. People wonder why we're failing at those expectations. And then we're all sort of left having fingers pointed at us as if we have failed, when fundamentally the flaw isn't the rules. It's that the rules don't match the actual funding. And I know we have a cost study coming out, but again, and these are not new comments on behalf of NAMI. We expressed this very vehemently when these rules were first drafted, is that the cart was coming before the horse in terms of expectations of what we could see in this state. Because again, the funding, we didn't ask for the funding first, and we didn't build rules around the funding. So with that comment, I'll sort of conclude any other commentary generally on these rules, and then limit it from here on out to any kind of specific feedback. But thank you for indulging me with that. And Krista, please.
I really appreciate your feedback, everybody's feedback. This is exactly why we're here. We want to hear what you're hearing, what you know, where we can lean in and kind of catch up to the times and the climate that we're in. That is my value in this process. And we also have to abide by what is in statute. And so I think that, let's navigate this together to see, what we can come up with. I also want to just add that, we're changing the model of the CFA. It's something that we're going to be talking about later today. To whereas before we were handing out, or not handing out, oh my gosh, we were providing the funding through service elements. And one of those service elements was service element 25, which is mobile crisis. And what we're doing now is we are providing the funding in instead in kind of 1/12 payment or 1/24 payment, whatever it turns out to be. basically the funding that each county receives, they will receive it without the service element classification, and so they get to prioritize the funding in their local plan. And what we've asked is, of course, populations, and to get to the closest, get to compliance with those populations. And we recognize that crisis of everything. And so we fully expect that as MHPs are developing their local plans and developing their budgets to really leverage that funding to the maximum ability. There can be some improvements area by area in terms of addressing those gaps, because we're specifically asking them, what are the specific needs, and then how are you going to address those gaps? And so if the specific need is that, we can't be in compliance with the crisis rules and we can't offer 24/7, then our expectation is to hear, well, what are you going to, what can you do? How can you set yourself up in a different way so that you can meet those needs? Crisis is just one example of a lot of different needs that exist in each county. So I'm not going to say this is an easy process. I do know that hard decisions have to be made, but we have to think about, what are those core services that need to exist within each community. So I hope that offers some helpfulness.
Right. Thank you. Lane, please.
Yeah, I'm going to jump in here and beat on your dead horse, Chris, but I'm going to give you some reality, OHA. So it's being discussed now, and some of not broad conversations in the law enforcement community. But Chris is exactly right. It keeps coming back on law enforcement. And of course, that's what we're trying to avoid, is because we just all know that it exacerbates the problem a lot of times and stuff like that, and by the state not funding it. And I won't get into all that because it's already been said. But I think OHA, you need to be aware that there are some law enforcement agencies, and I'm one of those, that won't respond to certain calls for service with individuals that are in crisis. And it all goes back to the governmental interest situation. So I guess what I'm really trying to say is that there is conversations, there are actual things that are happening in different agencies across the state. And I'll say that some of it is mine. There are some of them that are coming from city police and stuff like that. They're not responding to those calls for service because of the governmental interest part of it. Now, we try to do what we can to work with our CMHP, and we have a really good relationship with ours here, and we try to help them out the best we can. But there will come a point when, if the state continues to go down this path of non-funding, unfunded mandates, let's just call it what it is, there's going to be a jam up somewhere along the lines. We want to try to continue to partner when we can and when it's appropriate, but there is a legal point that we will get to in law enforcement where we will refuse to respond. And so I think that you need to take that into a very serious, consideration when you start reviewing and implementing some of these rules and stuff like that, because it doesn't matter whether it's funded or not. There's going to be a point in time where we don't respond, and there are those that are happening right now. So I just wanted to make you aware of that's happening. I know that's a broader part of this conversation, but it is a reality that is, in some cases, is here, and it's going to be coming more and more and more. So I guess I would encourage the state to, start figuring out some alternative solutions on funding and, and stuff like that. And don't force the CMHPs to do something that you're not going to pay for. So that's my
Right.
2 bits.
Thank you. So I think we've all gotten our 2 cents in. So we'll move on through sort of the more the specifics. I will point out, there is a cost study coming, I think by the end of the year or early next year, that presumably will tell us, hey, if we want to do a 2-person team, if we want it really available 24/7, meaning that it's not just in theory available, that if somebody calls, it is there. We will have a dollar figure that is something that might be a point of advocacy for us as a group, certainly for us as individual organizations or individuals interested in the crisis system. So some tangible information is coming forward that may help us in advocacy take action to support the actual implementation of these rules. So with that, I'll go back to Juliana and Brian. Please lead us through now the specifics, if you would.
Great. And Brian, I have switched screen share. So Brian's going to take notes separately, so you won't see the notes he's making, but he is going to be recording your comments and questions. And I also can now not see the chat, so I'm going to rely on our members here and my colleagues to call out when there's a comment or a question. All right, so I think the last one I talked about is certification to the rules. We also made a change here. Oh no, now I cannot. I am so sorry. I'll have to open this on another screen. I apologize.
I was toying around with it. I think if you select show comments and then deselect the show comments, you won't be toggling back and forth. It won't do that default where it takes you to the comments. Under the review tab up top. Sorry for the technical stuff.
Just for now, I'm just gonna open on another window and read them out, so I'm not futzing around with it. Okay.
I just wanted to note Robin's comment in the chat of wanting to know exactly like what's in statute that is also in rule that cannot be changed without statute changing. And we are getting that analysis now, Robin. So we'll be able to share that with this group. We were hoping to have it before today, but they're still going through the full statute. So we will have that back to this group.
Awesome. Great question. And thank you so much, Chelsea. So then the next change we have made is that the rule set will now reflect both of these distinct intervention models. We have a blend of our MCIS and mobile response and stabilization services. This is based on feedback from providers. It has been confusing to just separate out the stabilization services from the mobile response and stabilization services. So we're not going to write this to have the full model presented. All right. We've also had some questions about there is some inconsistency in how youth were referred to. So we're just standardizing using youth, meaning ages 0 to 20 and their families. This is to distinguish from the CMS definition of child, which is less than 18, but the MRSS model actually goes beyond child because it is inclusive of transition age youth. Okay. We have another reference to, I'm sorry, we have another reference to certification to Division 72. Okay. This is another smaller change that I won't call out, but community-based, we changed the definition of community-based to say means the location of the individual or family in crisis, again, to be more inclusive of that MRSS model. All right, the next change, frontier. This is a discussion topic. We have the word frontier. We have been considering changing this to remote.
My understanding, this was in keeping with the Office of Rural Health or OHSUs, so that they're consistent terminology. I mean, this word has come up many times in the past in rules. What would be the advantage to change that and not be consistent with the language used in other healthcare settings?
I think the concern, Chris, is that in the future style guide, there's discussions whether using the term frontier would be culturally appropriate or perhaps culturally insensitive. And so the proposal was to switch that to remote.
And where does that feedback come from? From people who live in remote counties, they don't consider themselves frontier and find that offensive, or what?
Tribal affairs.
So tribal affairs?
And tribal citizens as well. So internally it would be tribal affairs, but they're hearing that from tribal citizens.
Yeah,
But I would like consistency.
yeah, I think the history of that is that the word frontier is considering this area as frontier, has some colonial connotations to it. So the word remote has been brought up as a possible alternative to that.
I think until the full definition is changed, we need to leave it for consistency's sake. I understand completely the cultural connotation, but I think just for consistency, you can't change midstream in one rule set.
Okay.
Is that something that, I mean, OHA has probably a lot of rules that do frontier. Is that something that the agency can look to just do wholesale change then at some point? So it's consistent across things and
Yeah, no, that's good. This is Ebony. That's, good feedback because, I think that that's something that, has kind of agency-wide implications and is best when we can kind of, have that full definition shift and change. So that's something that I can definitely look at moving forward and thinking back. So thank you.
Great. Yeah, thank you. Because if it's worth changing, then it's worth changing everywhere. Yeah.
It absolutely is worth changing. I can attest to myself being very uncomfortable when I hear the word frontier.
Awesome. Thank you so much. We will move on to our next change. Because we are changing the section from just stabilization services to mobile response and stabilization services, we'll now need a definition for the full model. So we have a definition here. Just defining it for clarity. And this is draft language. So we're looking for any feedback on this definition as well. I think Danielle, you have your hand up.
I think Robin's
first.
Oh, Robin's first. Okay.
Yeah.
Yeah, it's comment that I really I'm very concerned about defining in rule that this includes up to 8 weeks of stabilization services. This doesn't work for every family. It doesn't work for every situation. When we start prescribing clinical interventions like this that are time bound in a definition, we're doing a complete disservice to anything that doesn't look exactly like that. And I'm super concerned about that because every situation is unique. And if I don't fit right in this box, the people providing the service aren't going to get paid. The people who need the help are probably not going to need the help. And there's been countless examples of this across the last decade or more, where we've done ourselves a disservice and stopped doing things that really worked because they didn't meet our fidelity model. Again, spent 3 hours in meetings yesterday tearing apart those things just to sit here and walk in today and see all these rule sets then, yes, when clinically indicated, and take out 8 weeks. People, take it out, including face-to-face intervention when clinically needed. That's fine. And why does it have to be face-to-face? Why can't it be including interventions as warranted, including interventions as clinically indicated? Because sometimes those interventions may be remote, depending on the situation.
Okay. Thanks, Robin.
Yeah, Danielle, please.
Yeah, I think my comments, I'm worried about having a system of care reference here. I understand what the intention probably was, but referencing making it an entry point for the system of care is misleading because the system of care isn't a service, it's a system structure. So having that referenced in a specific clinical intervention doesn't make a connection to me. I don't understand why we would reference system of care in the mobile crisis services rule set at all, because it isn't a clinical intervention, it's a system intervention. So this feels like a disconnect to me.
Great.
Okay, thanks, Danielle.
Thank you. And then, yes, is it Shira? I probably mispronouncing.
No, you nailed it.
Oh, great.
Shira.
Thank you.
Hi, I'm Shira. I'm the executive director at CBH, or CMHP in Clatsop County. And I just wanted to underline what Robin was saying, and I support taking out face-to-face and 8 weeks. It does feel a little prescriptive. The face-to-face component is really challenging, especially for rural communities who are trying to serve non-English speaking clients. And we often rely on telehealth services if we don't have Spanish speaking providers in person. So I just think that could be really limiting. I just wanted to agree with Robin. So thanks.
Great. Thank you.
Great. Thank you, Shira.
Any other comment? I would have a comment too, but I want to get everybody through. And Robin, your hand is...
Sorry, Chris. It's not a stale hand. It's actually a new hand.
Okay, please.
I'm curious about the last two sentences. MRSS services are driven by Youth and Family Voice, which result in service delivery. And of course, I agree with Danielle about the entry point for the system of care. I think those two sentences don't really help the definition. Those are philosophy that should guide over everything we do, but not be specifically called out within one singular definition.
Great, thank you. My feedback is this definition writes you into a box that where the details of this really are in later in the rule set, and it seems to me rather redundant to try to express what this is when it's expressed more elaborately later. So my advice would be make this a little bit more generic and rely on the more detailed rule set. Whether, the 8 weeks, is it really a national evidence-based model? I mean, absent of SAMHSA having a registry of evidence-based practices, who makes that judgment? Is it the state declaring that just because there's some research papers? These kind of specifics just don't serve this definition very well, whereas what serves the service better is the more elaborate rules later on. So it seems to me here's a better opportunity to be a little more generic, that these are specific services for youth and family that are to do X, Y, and Z. And that the other rule set can stand on its own in terms of the specifics of those things. So that's my comment on this specific definition.
Great. Thank you, Chris. And yes, we do go into more detail. So about what the mobile response and stabilization services are later on. So I appreciate that feedback from everyone. Okay, I think our next major change is stabilization services plan. So we have a lot of references to plans, and there's safety planning, there's the stabilization plan. So we have gotten a lot of feedback from providers requesting more clarity and need to consider some of the duplicative activities of all these plans. We've received feedback that this has resulted in administrative burden. So we decided to more clearly define the plan. So stabilization services plan means a structured short-term plan developed at the start of stabilization services with the youth and their family to prevent further escalation or the need for higher level care, enhance family skills and resilience, and connect those in crisis to appropriate long-term community supports and services. So we wrote this definition to really clearly define it from the crisis plan that happens at the end of any mobile crisis intervention. So somebody will see a crisis team, they'll make a safety plan that will carry them to the next service that they get. So this stabilization services plan outlines that this is something that occurs once they are entering that stabilization services part.
Any questions or comments here? I know I just have a quick question, sort of going back to the first page. Oh, Danielle, please go ahead.
Yeah, I'm just curious, Chris, if you want to finish your question, that's fine.
Well, I think it's more of sort of the intent is I'm picking up on the separation of mobile crisis and MRSS really is that does it set up a more realistic system in my estimation where the initial response may be the general mobile crisis. They just happen to be trained in youth, and that by separating out, then the stabilization services are truly this other thing where another team might be able to come in and do that piece.
Yes.
Am I understand that correctly? Great. Thank you.
Yeah, we had some confusion from our providers on which plan was which, and if this stabilization services plan had to happen at the end of that initial crisis counter with youth. We do ask our CMHPs to have a separate team that is youth focused that actually delivers stabilization services. So we wanted to make sure that this stabilization services plan was really specific to that sit down, or we've received the feedback just now that it could, even be telehealth, but that initial meeting to assess what those stabilization services will be to fit the needs of that family.
Right. The family, there's been a mobile crisis response, for example, the family is elected after that to say, hey, yes, we do want stabilization services. And now this is where this kind of thing kicks in at that point. Okay, great. Thank you. Danielle.
Yeah, I'm concerned about the stabilization plan. I have this mixed opinion about whether this definition is specific enough, but then also not wanting to make a definition that's too prescriptive. And I'm thinking more of a CMHP COA review where there's going to be inconsistencies in how the stabilization services plan is interpreted, and whether or not this will be a finding in the COA reviews if the definition is broad. So I think we need to balance either making it too specific, which I don't think we should do for the record, or making it too broad and making sure, if we leave it broad, that there's consistency in how this is evaluated for a site review, because I think that's going to be problematic, and COAs are going to have findings that won't be fair because this is a really broad definition that may be interpreted differently from a reviewer to reviewer.
Okay, definitely a good comment.
Danielle, do you have any recommendations of language other than not this? Is there a specific language or definition that we're trying to get to the advising part of like what would you put? I mean, here we don't have to do it on this particular one. I'm just thinking of taking the feedback back of trying to figure out what would be appropriate language or something that would make more sense that's not highly prescriptive.
Yeah, I mean, it would defer more to my CMHP partners, Cheryl and my CMHP folks that are on here. I just don't want this to be another place where there's, depending on who your reviewer is, there's 10 different interpretations for this definition that results in findings year over year because you're always chasing how that interpretation
so for us to loop
is
back
defined.
With CMHPs and the programs would be
Cheryl,
helpful.
is it okay for me to do that with your CMHP, Cheryl? I don't want to misspeak, but I also can see this being a problematic space.
Yeah, what I was going to say is I'd like to take this particular definition back to the CMHPs and see what their feedback is, and I'll bring it back.
That would be great.
Yeah.
Perfect. Thank you, Cheryl. And let us know if we can help too, because obviously we're going to want CMHP feedback on all of this anyway. So
yeah, definitely. Okay. Thank you.
Great. Thank you. All right. So you'll see that stabilization services definition was removed because we have changed it to mobile response and stabilization services. We've added a definition of system of care. This is added from statute. Sorry, my mouse is a little bit
Yeah,
slow.
and then Ebony has her hand up if I might go.
Go ahead, Ebony.
Thanks, everyone. I'm just driving back from the groundbreaking, so sorry for being off camera. And just based on the feedback, I just also want to make sure that we're noting on the OHA side, some of our efforts to just make sure that we are doing our due diligence around how we then go back and work with our licensing and certification team to assure that we're all clear on kind of set definitions so that then the system doesn't have to then work around us, if that makes sense. And so I just think that that's a note of action that we can continue to just build our due diligence around. So just want to note that.
Yes, thank you, Ebony. Go ahead, Brian.
Yeah, I just wanted to hop in along those lines and share a little transparency around why this definition is prescriptive. So adults across the lifespan can go ahead and get stabilization services, and oftentimes there's a stabilization plan once they discharge. And so with the youth model specifically calling out stabilization services in capital letters, we just wanted to make sure that there was a way to differentiate between the two, between what adults receive when they're at the end of their crisis services and what kids receive, youth receive when they're transitioning from the 72-hour crisis period to that up to 8 weeks when it's clinically indicated. So if you want to keep that in mind, Cheryl, and those others that are going to get feedback and put some more thought into this point, that's kind of transparently where we're at, struggling to differentiate those two definitions from one another.
Thanks. Yeah, I definitely also want to just emphasize what Ebony said is we are also working really closely with our licensing and certification team and our Medicaid partners to make sure that we're not writing anything in here that will be contradictory to what the expectations are of your certifications.
I just want to do a time check with you, Chris, and others that it's 10 after 11 and we're in the definitions. So,
I was just about to say,
thank you.
I'm looking at the agenda stuff, and I know when we talked about the things that we might push off, we talked about maybe pushing off the CFAA stuff if we needed to the next month. Not that we want to do that, but just putting that out there, that the co-chair, we've all discussed that. But yeah, let's see if we can get this done. Okay, thank you.
Okay. Yes, I will try to move quickly too. So our next major change here is crossing out all of these changes, all of these specifics here. We have all of these areas contained within our Mobile Crisis Training Academy. So that's our self-paced, our in-person, and our virtual training. We just wanted to make this more concise and reduce any confusion that these would have to be trainings that would be done in addition to the Mobile Crisis Training Academy, because they're already in there. We don't want you having to double train people if not necessary. There are a few that we did leave. So lethal means counseling and first aid and CPR, for example, are not contained within that Mobile Crisis Training Academy. So those are the only two that we'll call out as needing to be done separately.
I think it would be helpful in this area because it may cause consternation to see things, specific things disappear. If there is, I don't know, website or something that from the outside looking in, you can go somewhere and see what is that training, all embodied in that training. The other comment I would make is I still don't understand why mental health first aid is required. It's not, presumably we're not going to have crisis workers who need mental health first aid because they are going to be a QMHA, QMHP, or some other discipline other than a lay person. I mean, that's really what mental health first aid is aimed at. So I just don't understand why we would require an 8-hour training of anybody. If they need that to become a crisis worker, we're in trouble with that, the qualifications of that person.
I think that's first aid CPR, not mental health first aid.
It's on the next page. It's mental health first aid, optional for QMHP and QMHA.
Got it.
Right. So we did change it to optional for that exact reason, so that QMHPs and QMHAs are not required to do that.
So, but we don't envision, is there a worker that we envision being a crisis worker and qualifying who would have to take mental health first aid?
Yes, the list of staff that can be a part of the team are extensive beyond a QMHP and a QMHA. It could be peers, it could be EMTs. There are different types of workers who that would be a good fit for.
But they would still have to take the other training through the Oregon Mobile Crisis Training Academy, correct?
Correct. Yes.
Okay. I'll just let my comment stand on its own. I don't find that 8-hour training, having done it and having delivered it, pertinent to this work if we're going to do these other intense trainings.
So recommend removing it, Chris?
Yeah, I
Just
think so,
remove it
because
as a rule?
it's so general. Like it should be,
Okay.
if we're going to have a peer doing this work, that should be in the mobile crisis. Like the training should be there. And that's the body, I think, that has the expertise to deliver the trainings that our providers need. And I know that's probably going to cause some people consternation as well, because that was a big topic of conversation when these rules were first promulgated. Robin, please.
I was just going to agree with you on top of the fact that mental health first aid can be cost prohibitive. That puts up a barrier for people in order to be able to find it, to be able to afford it, et cetera, et cetera. And also, again, hearkening back to conversations yesterday, when we're calling out QMHA and QMHP and we're not calling out licensed providers or things like that, it's a very stylistic issue that just causes so much confusion. Because there's still people who think, oh, I need to have my QMHA or my QMHP, even if I hold a license, and that's just not true. I would recommend striking it.
Yeah, great. Shira, please.
So our CMHP has been doing this for decades. Like we've been offering stabilization services to youth. Any youth who enters our crisis system gets immediate supportive service, gets transitioned to our child and family team, gets the appropriate clinical interventions. And so my thoughts around this are like with the Mobile Crisis Academy being required as a component of the stabilization services, like I understand that the Mobile Crisis Academy is appropriate for crisis workers and crisis responders and the folks that are like doing crisis intervention. Crisis stabilization work is like intensive in-home. It's, it's increased services sometimes that are community-based or office-based. And so what I'm reading when I look at this is that I'm going to have to send basically my entire child and family department to the Mobile Crisis Academy because that's the team that's doing the stabilization work. So I'm just wondering about that.
So maybe a recommendation might be, since we're separating mobile crisis and MRSS and trying to treat them distinctly, is there a particular set of training or skill set that ought to be just applicable to people providing the stabilization services? And maybe that might excuse them from the mobile crisis stuff.
Yeah. Well, and I just think that I get that like we're talking about MRSS as this whole thing from like crisis call and response to, up to 8 weeks of clinically indicated care. But like, that's just, they're different skill sets are required at every point in this patient or client's experience of engaging with the behavioral health system. And my crisis workers need a different set of training than my child and family providers that are doing stabilization work that are potentially in-home or community-based or clinic-based. So so I'll stop there.
I think that makes sense. I get the sense Chelsea's on board with that. So the message has been heard. And maybe, I don't know if there's more commentary on this exact point, but maybe Chelsea, I think we've said loud and clear, hey, maybe go back and look what's pertinent to MRSS, what's pertinent to crisis. And if somebody's doing both, then they may need both.
Yeah, Chris, you're right on spot there. When we scroll down a little bit more, you'll see a specific training requirement that will be self-paced as well, just for stabilization services. And so we'll make it more clear where the requirements lie, but I think that's addressing the concern that's being stated.
Yeah, I think it's just in those rule set, making sure there's clarity. Like if I'm just doing stabilization services and I'm not doing mobile crisis, then probably I don't need the elaborate mobile crisis thing. I think that's what Shira is really talking about. Yeah, great.
You can make it more clear.
Yeah,
And
I
then-
think it just says program staff above all of the mobile crisis, so we can make that more clear.
Yeah, great. Thank you. So we've, I think, addressed that one. Robin, is this a new commentary, I hope? Robin, you're on mute if you're speaking. And maybe that's a legacy hand. Cheryl, go ahead, please.
Well, I think that's a good distinction, and I would say the Mobile Crisis Academy really is focused on mobile crisis responders. There is a section on MRSS, but I think most of the people who attend our Mobile Crisis Academy are mobile crisis responders. It's good for them to know about MRSS, but it's really not for that set of staff.
Yeah.
So I agree with the separate training is what I'm saying.
Wonderful. Thank you. Brian, please.
Yeah, I figure while we're having an open dialogue about this, I want to throw out the idea of this stabilization services that's independent from the mobile response piece. And then curious if I could get some input from folks about how that would look like stabilization services. Would folks call the county crisis line or 988 and then set up an appointment for stabilization services because their acuity is not high enough for a mobile response? Or would that just be a service array that's available to folks who like do like a walk-in for short-term bridge services? Go ahead.
Well, I think, will the rules later tell us the access points for this?
Yeah, it's intended to be a follow-up for the mobile response piece. And so I'm just wondering if there is no mobile response piece, how do we get that follow-up and what does it look like?
But why would there be an MRSS availability if it wasn't following a mobile response? Because if the intention is that mobile response MRSS, it feels like creating a workaround that someone can just call and say, hey, I need MRSS is just going to overload the MRSS system versus just having that direct connection to crisis. I would advise against that, given the system that's already in place and the difficulty it's going to be. I don't think it should be Sally calling, hey, I have an MRSS need. It should be Joe from the CMHP saw Sally in crisis and does the internal referral.
Okay.
I do think, one commentary is, a lot of us were disappointed that CATS went away because it had proved its value in certain communities when somebody touches an emergency room, which may, so kids are still going to emergency rooms and there's not a mobile crisis response, may need that stabilization services. So that would be another entry point maybe to consider if it's not already included. Shira, please.
I mean, I think this is more about like data collection and how we're tracking it. Like the reality is for CMHPs, like if kids need a more intensive level of care, like we're delivering that care. And so like call it MRSS or not. I think that maybe just is about the access point and maybe more important for data collection. But like we're going to assess a kid and their family. And if they need to be seen, 2 times a week and have it peer, then that's what they're going to get. Like we're going to tailor that clinical treatment to serve that family. If they come in through our crisis team, we're going to call it MRSS because that's what it says in rule. And that's the follow-up. But they're going to get the clinical care that's indicated, kind of regardless of whether they're coming through a crisis system, the emergency department, a pediatric referral, or the school.
Shira, just for curiosity's sake, you have the ability to deliver those services outside of being certified as an MRSS, right? I mean, there are billing pathways to do what you're describing without sort of falling under this rule set. Is that correct?
Correct.
Yeah, great. Thank you. All right, let's keep going, please.
Okay, great. And then above this call out about MRSS training, we've also stricken the 3-year requirement. Providers have raised concerns around administrative burden, so we're removing the requirement that staff receive training every 3 years. Again, this is a discussion topic. If we wanted to remove it completely, if we wanted to do every 5 years, or if there are people that think that every 3 years is a good rhythm to keep our retraining at. We're definitely open to some feedback on this one.
Yes, Shira.
I think once is one and done is fine. The reality is that the most valuable training that our staff get is in the field. And they're going to get that every single day. And all of our providers have required CEUs for the credentials that they carry, which are already really extensive. So I don't think any additional required training outside of an initial, excuse me, is necessary or appropriate.
Thank you. I think, from NAMI's perspective, I would look to the agency based on the credentials of the people doing this work. What are the CEUs that are required? And could you just add on, rather than repeat all the trainings, could you add on a CEU requirement that sort of fits in the regular rhythm for those professions? Other commentary on that point for feedback? Great. Thank you. I think we're ready to go or keep moving.
Okay, looking for our next major change here. I feel like I've missed something, but I guess not. Okay.
And pertinent to that last conversation, Cheryl put in the chat, we do offer refresher courses. Maybe there's some way to sort of make those refresher courses accessible and build that into the CEU. Sorry, I just saw that comment.
Okay, so for 2, we just changed this to present tense, just for clarity. Go ahead, Robin.
Yeah, this is one that I know we had extensive conversations around in another setting, in another meeting. It causes problems in areas where, looking especially with areas that hospitals that do not have a psychiatric facility. Sometimes somebody may be admitted to a hospital, but not to a psychiatric unit. And I think that was specific to be MCIS may not be provided to an individual that has been admitted to a psychiatric unit, not necessarily a hospital. Because if a hospital doesn't have a psychiatric unit and they don't have any other psychiatric support services, mobile crisis would be appropriate. So I think that was meant to say psychiatric unit and not hospital.
Oh, like in a medical bed, you mean, Robin? Like if they
Yes.
go up to the floor? I got it.
Yes.
Yeah.
Yeah.
Okay.
Yeah.
Thank you. That's really
Yeah.
good feedback.
Thank you.
Okay, thanks, Robin. Okay.
And Shira, please.
Can you scroll back up to the
Yes.
hospital piece? MCIS may not be provided to individuals. And is not. So I don't know, that this feels very like gray and kind of convoluted, and also feels like it's sort of about the MOU relationship that our local hospitals have established with our local CMHPs. And that's really different for every hospital and their social work capacity and what they want. Sometimes they want us there, sometimes they don't. So I just want to make sure that we're not putting anything in here that feels prescriptive for any working relationship between the hospital system and a CMHP. I want to be able to develop our own agreements based on what works for both agency capacity.
I think this achieves what you're talking about, Shira. It's
Okay.
clarification based on some long conversations that came before this body earlier, that just provide us clarity. There was some discussion of, can even mobile crisis respond to a hospital campus? And so the distinction became somebody admitted, not admitted.
I see.
Somebody in an emergency room, MOUs that can do that. Like and then I think the clarity that Robin just added was making sure that if someone's in a medical bed, for example, in a rural hospital, that the mobile crisis can respond to that because there is no expertise on staff there to accommodate a behavioral health crisis, for example. So I think that's the clarity that will be provided here, is that would be permissible but not required And that
Okay.
would then be the part of where the MOU would come into play.
Okay.
And
Thanks for that.
I'll look to Chelsea to tell me if I'm summarizing that correctly, or Lauren, or somebody with better knowledge.
Yeah, I think we want to just hear from you all, and we can take this back, right? And sift through like other previous decisions and all the things. But I think it's distinguishing this. The complexity comes around whether you're credentialed to, operate or do something in a hospital. Can you bill Medicaid? Like it's complex. So, but I hear the feedback loud and clear, because I do know that hospitals do admit people to get them out of the emergency department, because that's not a good place to be when you're in any kind of crisis for a long period of time. So appreciate that.
Okay, I don't see any hands up, so I will move along. Thank you, everybody. Okay, the next comment. Sorry, this is very small. So we have this here under one other trained behavioral health professionals defined in these rules and in Division 19. So this is a discussion topic at the August BookSac, and this is also feedback we've received from providers as well. But at the August BookSac meeting, a suggestion was made to allow EMTs to be part of the 2-person team. Is that something that we'd like to consider? Are there other types of professionals that we would like to consider as well?
Great question. I think there was a good conversation that we would want EMTs if they're able, but require them to take the trainings that are pertinent to being a crisis worker. Was that, I'll look to a group to see. I see a thumbs up from Robin.
Yeah, there are folks out there that are trying to use EMT roles as part of their crisis response team, and that's what they're doing, Chris. They're giving them that behavioral health training and then relying on their medical training from the EMT programs they've been in to assist with that.
Yeah.
And it's been fruitful, so we've heard. So.
Yeah, I think as long as they're trained, it would make sense, right? And I see Lauren in the comments that was Stacy Brubaker's suggestion last month was good. Barb mentioned that Portland Street Response has an EMT already on their team, so it seems to be something that people are interested in and already deploying. Danielle, please.
Sorry, my camera is being a little glitchy. Would there be additional training we would require from EMTs given that they don't have behavioral health background? That if we're going to provide or allow EMTs, that's fine. And I know we had the whole discussion about mental health first aid. I don't think that's the right route. It feels like these individuals could potentially need additional training, though.
Would it be sufficient to put them through the mobile crisis academy, or I forget the terminology?
Having not sat through that, I don't know the answer to that question, Chris, but I feel like if we have QMHAs and QMHPs who already have a base level of mental health training or behavioral health training, and that's a requirement for them, it feels like for EMTs who would not have that foundation to have additional training. And maybe I'm overthinking this. It feels like we're setting EMTs up to go work in a field that they have no foundation to work in, without really setting some standards.
Yes, no, I think that, and I remember our discussion when we talked about this was making sure that folks were trained and that if they were going to do that work. Lauren, please.
Yeah, I hear everything that you're saying, Danielle, and I think that's a really important point to raise. I think one thing to consider is that is kind of the beauty of a 2-person team is, an EMT is going to have to be paired with a QMHA or a QMHP in accordance with how the rules are currently written. And so being able to play off of those skill sets while also having the Mobile Crisis Training Academy training under their belt could potentially be a really nice balance. As an example, my understanding is that Jackson County, the way that they run their team right now, they utilize Mercy Flights, which is EMTs, as a 3rd person. But if we were to do this rule change, that would allow them to be the 2nd person and help with some of the workforce challenges as well. So just throwing that out, that I totally hear your concern around, are they going to have enough training? But potentially they do, and maybe they have training in a different way in the different interactions that they have in their role as an EMT.
Is it possible to get more information on this front, to know more about EMT training and what behavioral health exposure they may or may not have? Would that
I think this is a perfect opportunity for us to kind of lean on Stacy Brubaker as one of our committee members to kind of see if there's any information that she can bring to the committee.
Yeah, we'll have to, she had to drop off early.
Right.
So maybe if we could query her.
Mm-hmm.
Okay, Shira, please.
I think like the fundamental question that has to be asked about EMTs being a part of the team is why we would consider that. So if it's to address a workforce shortage, then I think we're looking at maybe having some enhanced training for EMTs if the expectation is that they're filling a behavioral health gap. That's one thing. If we're allowing EMTs to respond as a component of the team, because like you said, Lauren, they're bringing a different skill set, they're bringing a different value, a more diverse lens, and maybe a more well-rounded team to approach a situation, then I don't think it's realistic or reasonable or necessary to expect that they have the same level or even close to the same level of training that we're asking our mental health professionals to have. So I don't know what the answer is. I don't know why EMTs were considered, but if it's the latter, then I don't necessarily think they need additional training, personally.
Thank you for that. I would say from NAMI's perspective, having interacted with EMTs, they need something, because the danger is if they don't have anything of actually inadvertently escalating a situation, which you can see in the co-responder model if the law enforcement officer is not better trained. And so I think that's the consideration. Then the question is, how elaborate is that additional training, given they come with a baseline of medical training and that kind of thing. So that would be the question from NAMI's perspective. Robin, please.
Yeah. In the physical side of the world, the other side of the world, because we're bifurcated, there have been significant conversations at the area trauma advisory boards, especially in, I believe it was Washington County, where there's a belief around creating an EMT level that has additional psychiatric training specifically for this purpose. And there's some actual training materials in the physical world around that. I need to go back to, the trauma medical director who was over that project. But Aditya Jamalani and I dug in on that a couple of years ago when we were proposing our work around looking at how we did trauma regions for kids in crisis, in that whole networked bill that we put together a couple of years ago. I think that it's, to Shira's point, I think it's a both and. I think it's a workforce issue in some communities. I also think that they do need that additional training and able to be able to do what Chris is talking about. But that training recommendation may already exist under the Trauma Advisory Board. It might be a good question for those folks to ask to see if we can access that.
Robin, can we task you with sort of a little bit of follow-up there?
Yeah, go ahead. I can figure it out.
And then Chelsea, I see your comment on the trainings group would want. I think we don't have enough information yet to really make a recommendation. So I think we need to gather a little bit more information and really understand, like somebody like myself really needs to understand what do EMTs already know. And then look to our partners like Shira and Cheryl and Stacy. What would it take? What would be specific to EMTs that would help them gain the knowledge that we all feel they need so that they could be part of that team? And to Shira's point, it may not be the whole Mobile Crisis Academy. It may be something different. I don't know that any of us, at least I can't tell you a recommendation yet on the specific training.
That's great. Thank you.
Okay, let's move on.
All right.
I know you asked the question, Juliana, about other professions, but I think in the name of brevity, let's close the discussion to EMTs.
Thanks. We can see in healthcare crossed out up here, just acknowledging that inequities exist beyond healthcare. We also added 988 centers because in the last few years, we have added chat and text to our system. So these requests may also come through as a chat or a text. So just acknowledging that this may not be just a call. All right. 11, we removed co-response from here because there is a specific co-response model. We talked about it a little bit earlier, which is not prohibited, where there is a crisis worker that's embedded in a law enforcement response. So we just wanted to clarify that law enforcement may be present, where law enforcement might actually be called in by a mobile crisis team or a mobile crisis team, or law enforcement may call a mobile crisis team, but that it is distinct from an actual co-response model. So we wanted to make sure that that was clear here. Okay. All right. We changed protocols to procedures.
Juliana, can I ask about that?
Yeah.
Are you guys changing that language consistently across all of the rule sets from procedures to protocols?
That I will have to check up on, unless there's somebody here that can answer that question.
I'm trying to think where else it lives. Are you thinking of something
Well, I'm thinking in
specific?
the 019s, Chelsea, there's 1,000 different policies and procedures that COAs have to have. And I think for consistency, it should be either policies and protocols or policies and procedures in all of the rule sets.
Yeah, let us take that back because we're never going to open all the rules at the same time. And so, but there is a project specifically around the 019. So let us take that one back with the frontier question. That's a great call out.
Okay. All right, we changed mobile response to MCIS just to clarify that this is responding to the lifespan. Okay. Down to 14. Okay. Providers must have written agreements in place with any 911 center in their service area that is willing to collaborate. If a 911 center is unwilling to collaborate, providers must document the attempts. This is in response to challenges that some of our providers have told us about. The prior language was a little bit inflexible in the case that a 911 center is unwilling or unresponsive to cooperate in an agreement. So we just wanted to make sure that our CMHPs or our providers are not being held to these scenarios where their 911 center is not responsive. Okay, and then I think after this, we do get into MRSS. Oh, wait. Again, we changed this to the location of the individual in or family in crisis. And yeah, okay, so here is MRSS. And just so we don't have to switch, Brian, I can keep screen sharing and I will let you take over.
Yeah, I'll go ahead and point out the changes if you want to screen share, and then I can take some notes too. So this section is where we're going to see some significant changes. And we attempt to further define MRSS down here. And then we point out the rule set that needs to be used to provide those services. And then call out.
Brian, if I might, your first paragraph here in red,
yes,
that's a great definition for the definitions section.
Okay.
It seems to me you're saying what it is without being so prescriptive. You got it right there.
Okay, perfect. I'll call out the cut and paste on that. And then I should point out that again, number 2 here, right after the OAR callouts, this this does point to a delayed response, which is new. We're hoping that that delayed response will meet the needs of individuals who may not rise to the immediate level of a crisis response because their acuity may not be high enough, but would still like to avail themselves of children and family services. And I will just call out here that Danielle made a comment previously when we were talking about that in reference to administrative burden as well as a very increased volume on the crisis response staff. Shira, go ahead.
That mean delayed in-person mobile response? What's delayed? How long? What if we get them to come into the clinic? What if we see the kid at school the following day? Like, what is delayed?
Okay. So we'll define delayed. Do you have any suggestions that, I mean, like if we went too far in defining that, because that seems to be the theme today, is we're getting called out for putting parameters around this. If you could define time frame for
I think that it's like this whole thing is like youth, family, voice, and choice, right? So I think that it's maybe that's just what you reference here is that when a youth or their family is provided telephonic crisis supports and the crisis is de-escalated, but they request, in-person services, that the organization will respond or provide that care appropriately and as indicated, right? Like maybe I'll send somebody out 5 hours later, or maybe I'll schedule them for a follow-up appointment and see them in clinic the next day. I think it depends on what the family wants, what they need in that moment. And this feels like what you're saying is I have to send someone out into the field in a delayed capacity if I haven't sent someone else in person, but they might not want that or need that.
I think that's what happens in some areas is that if it doesn't rise to that level, especially for children for mobile crisis, then somebody doesn't go. So I think you're exactly right. So how do we put in rule to connect that dot statewide for those programs that may not be set up like that? So if you have suggested language, I think that would be really helpful. That's great.
Yeah,
Thank
I
you.
would suggest using language. I agree with Shira. I would suggest using language about when requested or when clinically indicated, because there also may be a point at which this is counter-therapeutic to go knock on someone's door 4 hours later and say, oh, by the way, are you still in crisis? Hi, I'm here to help. So I think we need to lean on the therapeutic appropriateness of this response as well, because we don't want to reignite the crisis if we've been able to avoid that by de-escalating via telephone services.
Well, it does seem you want a little latitude to triage too when you have a scarce resource, the clinically indicated or therapy or some qualifier language, making sure the response matches the need. It should be permissible to those providers. Robin, please. Shira, is your hand still up, or is that a new comment?
It's an ongoing comment, but
Okay,
Robin.
well, let me jump to Robin and then Amy.
That's
and then
fine.
we'll loop back.
I'm just curious, what problem are we trying to solve with this line altogether? I mean, why not just strike the line? Because it seems to be, again, I think, Brian, it was you who said that it's being very prescriptive when there's clinical judgment involved in here. And I don't know that we need to be this prescriptive. So I'm trying to understand what two is trying to solve.
I think the biggest
Explain
one is,
that.
I think the biggest one is that children, and you all know this, like they, and a lot of the crisis calls, and Amy, you could speak to this as well, where, a 10-year-old's going to wear themselves out probably while mom's on the phone trying to explain, but it doesn't mean that the crisis is over. It means that that incident that was just happening, and really trying to see this as an opportunity that, when a parent's used all of their resources and they're calling for help, it's an indication of a much larger situation that's happening. So, and part of this issue, again, we hear this at 988 call centers as well, is that parents don't know to act, like they don't have the secret language of what to ask for, right? They're asking for help. So I'm trying to think of the list, right? There's a list of things that we hear in the children's system that sort of a typical mobile response wouldn't necessarily pick up for children.
So then the
And
language, Chelsea, maybe should be offered. Must be offered an in-person response. And I
Yeah,
think then it's to the discretion of the provider, to Shira's point, whether it's 5 hours later the next day at school, 48 hours later, whatever the clinical judgment is. But I think offering it is
so
the
that they
key.
know it's an option.
Yes.
Yeah, that's
Yeah,
great.
and I can confirm, Danielle, the way that you just described it before is the intent behind this, with the making sure that the offer is there. And just to add, Chelsea has it exactly right. And just to add to that, to hopefully answer your question, Robin, we have previously for the mobile response, mobile crisis intervention side, we have requirements that in an urban area, the response has to occur within an hour, rural within 2 hours, and then frontier within 3. So this is a call out for the mobile response and stabilization services for those scenarios that Chelsea just described, that the family would have the option, instead of the mobile team coming that night, maybe their child is having a crisis in the middle of the night and has, they've gone to sleep, that they would still have the chance or the opportunity, if it fits their needs, to have that mobile team come out the next day or the day after, whenever works for them. So we're kind of exploring what that delayed response could look like.
Before I jump to Amy, are we asking the same mobile team to come out that's skilled in crisis, or are we asking someone with more expertise in the stabilization side of things to come out? And maybe it's the same person, but maybe not, right? Depending on how they sort of divide their team. It seems to me if it's delayed enough, what you're offering is not a mobile response. You're offering an in-home or in environment response. But the key will be, do you have the right person going or right team? Anyway, just throw that. Amy, please.
Yeah, I mean, I agree with the folks that were talking about language like offered and requested, because someone just showing up after the situation, after the meltdown has resolved or after the situation can just re-escalate it. I also, in parents, I know especially in the IDD community, there's a wide range of, I mean, I know somebody that called our local crisis line because their kid was freaking out about a bumblebee before a rafting trip. And, so there's like a wide range of kind of how services are used. And I think just thinking of resources, it's important to, have specific language about being offered, being requested, and things like that. And then ultimately, like, again, what is the connection to the services that don't exist that can support long term?
Great. And then time is growing short, so Shira and then Brian, and then hopefully we can wrap up, get to the other piece on the next page.
Yeah, I just want to like call out that I think that that's been like the tension with this programming, like from the get-go, is like the sort of like the family voice and choice. The family gets to determine what's a crisis, and that the team is required to dispatch sort of like no matter what. And like the reality is that that's not always possible for two-person response teams, for all kinds of reasons, for huge counties, for multiple crises occurring at the same time, for exactly what Amy just referenced. And this happens a lot more in kid services, where like a crisis is really different for a child who's 9 and who was stung by a bee and is having a tantrum, and the family calls for mobile crisis response. It's really different than somebody on the Megler Bridge that my crisis team has to respond to. And they're going to have to prioritize in that moment, right? And so I clinically indicated it's really important language. There has to be like some discretion given to the provider organizations to make judgment calls about what we're able to respond to, what really requires in-person response, but then always, every time, offering that follow-up care. Like anytime someone engages with my crisis team, my child and family team is responding in follow-up to offer some kind of response to them. So I think that there's tension there, but there's a balance that can be found for the state and for provider agencies.
All right, thank you. Brian, please.
Hey, I just wanted to point out I've got 1 minute left, and then we're going to move to public comment. But Juliana, if you could scroll down to the next page where it reflects 7, 8, and 9, um, there's a lot of red ink here, and so I want to just kind of give a brief overview of what we see here, and let you know that the recommendations and suggestions that you gave up above, I will incorporate those here when we're talking about administrative burden, workforce issues, and whether or not we as OHA can mandate a relationship exists between you and your local hospital. So I'll suss the wording out on that with Juliana's help, and then take those changes and get back to you. But it's time for public comment.
Well, if we might, I want to, so forgive me, Brian. So as chair, I'm going to
over to Chris.
Privilege, and we're going to finish one or two more comments here, and then we'll move to public comment.
Okay.
Do we have any quick comments? I know I just have one. So I think the only comment I have again is the must language around emergency departments and other things. What happens if you have an entity over which the CMHP has no control and doesn't want to participate, is not willing to sign an MOU? I'm not envisioning that happens. I would imagine most healthcare facilities, but I might revisit must and see what is the relief valve if partners are for some reason not getting along. But I think it is important, these are additional entry points where stabilization services are important, particularly in the emergency department, because I do get a lot of commentary from certain quarters about the cats sort of disappearing. And so that I think symbolically it's important that emergency departments are a clear point of entry. Right. Any other comments on this real quickly? So I believe we do have the opportunity. Was there a date on written comments as well? I forget at the beginning that
No, we're not in our formal process. This is just, we're
Okay.
just sort of gearing up and hearing. We wanted to start with you all as, again, we've incorporated what we're hearing from providers ongoing, but we'll make sure to continue. So keep thoughts coming. You have the document there. As we get new versions or we get, different, as we move into a more formal process, obviously we'll keep you in the loop.
Great. Thank you.
As we go. Yeah.
It's good discussion. All right, Dean, if you could get us through the public comment period, please.
Absolutely. Thanks, everyone. Dean Carson, he, him pronouns. I'm our 988 communications officer. We are now open for public comment. A reminder during this period, it is open for anyone from the public to share thoughts and opinions. It is not a forum for us to respond to those comments. So with that, we leave it open to the public. Feel free to put things into the chat or raise your hand. Barb, please.
Yikes, I had my screen blown up. I couldn't find my microphone. Hey, everybody. Actually, speaking of that language changing, I'm hoping people can think to say turning the microphones on and off instead of mute and unmute, even though it says mute by the little button. Anyway, my name is Barb Rainish. I use she, her pronouns. I am in Multnomah County, and I'm going to throw something in the chat because yesterday at our local Public Safety Coordinating Council, affectionately known as LIPSIC, we had a presentation about ERPOs, which are the Extreme Risk Protection Orders. It's like the red flag laws and how to get guns out of the hands of people who may be suicidal or homicidal. And there was a lot of really good information, including how they're used to varying degrees across the state. And there was also information nationally too. So I'm just going to put a link in the chat, and if anybody's interested, it was the September meeting. My other comments have to do with being concerned about Portland Street Response, getting crisis funding, if that's even possible when I'm looking at how the rules are being written. and what the local intentions were a few years ago when it started up. So I just want to keep throwing that out there. And that's what I've got. Thanks for letting me talk.
Thanks so much, Barb. Anyone else interested in public comment? Great. We will turn things back over to the tri-chairs. Thanks.
Great. Thank you, Dean. Thank you all for a good discussion. I know a lot of folks were silent through this, so if you do have commentary, Brian, I believe, and others have put email addresses in there. Shri has offered to be a conduit as well. If you don't feel comfortable communicating directly, so there are still a multitude of ways to provide feedback. We as the tri-chairs are always interested in hearing from you guys. If you're more comfortable sort of communicating behind the scenes. With that, we get 5 minutes back in our day. So let's get out of here. Thank you all for being here today.
Thanks, everybody.
Thank
Take
you.
care.